I will now be talking about when and how to use breast MRI as a problem solver. As I mentioned before, we had some great talks about extent of disease and other diagnostic indications for breast MRI. So now I'm going to focus on just problem solving. So the ACR says that there are two categories in which problem-solving MRI it may be indicated. One is that if there is a concern for recurrence of breast cancer in women with a prior history of breast cancer, and when the mammo or the clinical exam or ultrasound findings are inconclusive. Then the second category is lesion characteristics and characterization. And this is rare, but it's when mammography, ultrasound, and physical examination are inconclusive, but there is still concern for breast cancer, particularly if clinical suspicion is high and the mammogram and ultrasound are normal, such as bloody nipple discharge. Of course, when there's appropriate uses for problem-solving MRI, there's going to be inappropriate uses. So some inappropriate uses, which I'll go through in detail at the end of this lecture, are one, breast MRI should not precede or replace diagnostic mammography or ultrasound if you have clinical signs or symptoms. Start with mammo and ultrasound. It should not supplant careful problem-solving mammo and sonographic technique in the diagnostic setting. And finally, it should not be used in lieu of a biopsy of a suspicious finding that's better seen on mammography, ultrasound, or even on clinical examination. So why do we use problem-solving MRI? In the appropriate setting, we have very good sensitivities, 93 to 100%. Specificity ranges a little bit more, between 37 and 97%. But in particular, problem-solving MRI has a high negative predictive value, 91.7 to 100%. That means if the MRI is negative, usually clinically or on mammo or an ultrasound, the patient is okay. So now I'm going to put problem-solving MRI cases into three buckets. BI-RADS 4 findings, either on mammo or ultrasound or another imaging modality. Second bucket is equivocal or uncertain imaging findings. Is the lesion a true finding, or is there changes at the lumpectomy or surgical site? And finally, negative imaging with a high clinical concern. So problem solving for BI-RADS 4 lesions. Again, I want to emphasize that this problem-solving MRI should not be used in lieu of a biopsy of a finding that's well seen on mammo and ultrasound. And this is because the negative predictive value of MRI is too low to avoid biopsy, especially in calcifications. The negative predictive value is up to 84% for problem-solving MRI in calcifications. Not all calcifications enhance. What are some situations where it's indicated? Difficult biopsy due to technical issues. Say it's the posterior breast and you might be better able to see it on a breast MRI. If you have a rad path discordance after biopsy or surgery, and I have a nice case of that in this talk today, and if you have a single view finding such as distortion, the preferred management is to do biopsy under tomosynthesis guidance, but if you don't have that, you may use MRI, and you can biopsy it under MRI if there's any suspicious enhancement. So here's our first case. This is a 55-year-old woman with new findings on screening mammography, and this is with full field digital mammography, no tomosynthesis. And so this is a CC standard view of the right breast, and you can see here there's an asymmetry that persists on spot compression views with some suggestion of distortion. On the lateral view, that there is no correlate. We started with targeted ultrasound. Ultrasound was negative. However, this is quite a suspicious finding. It's a suspicious single view finding with suggestion of distortion. No tomosynthesis biopsy capabilities were available at this site, so problem-solving MRI is indicated. And you can see here on the axial and sagittal views, you have an irregular, homogeneously enhancing mass at 12 o'clock corresponding to the mammographic finding. And on ultrasound, you have an irregular hypoechoic spiculated solid mass. Ultrasound-guided biopsy was performed. This is a grade 1 invasive ductal carcinoma. So here's another case. This is a discordant rad path correlation. So 75-year-old woman, prior history of breast cancer. You can see the surgical clips, the distortion, and she's presenting for screening mammography. On her screening mammo, there is a new mass in the posterior central breast for which ultrasound was recommended. You can see in the right breast at 9 o'clock, 1 to 2 centimeters from the nipple, there's an irregular hypoechoic small solid mass, suspicious, and a correlate for the mammographic finding. An ultrasound-guided biopsy was performed. You can see the biopsy device traversing the mass, and the result was invasive ductal carcinoma. So this is our clip films, and it's important to really look at your post-biopsy mammogram. Assess the location of the clip to the original finding. So in this case, you can see here is the clip. This is a wing clip, and this is the mass with a focus of gas within it. So the addendum to the dictation said, the wing-shaped clip is slightly anterior to the biopsy site. Pathology findings are invasive carcinoma, ductal and lobular features moderately differentiated. This result is malignant. So, repeat mammogram is recommended prior to localization to ensure a relationship between clip and malignant target. Of course, she comes back on an extremely busy biopsy day to the wrong hospital for the same day surgery. So we fit her in, but however, the radiologist that day did not read the addendum. And so you can see here, you can see the clip very nicely under ultrasound. And this is our seed needle, and you can see very well positioned next to the clip. But if you take a look at the seed picture, you can see that the seed, which is right here, is well positioned next to the clip. However, the malignant mass is distant from the seed and the clip. So the final surgical specimen was reviewed by the radiologist, and you can see they thought they saw the seed, the clip, and what they thought was the target. However, the final surgical specimen said residual invasive carcinoma is not identified. And we know that there should be residual invasive carcinoma because on the post-biopsy mammogram, we see a remaining spiculated mass. We started with mammogram and ultrasound. Can we find this little mass so that we can guide the surgeon to remove it appropriately? But there were so many post-surgical changes, no evidence of residual malignancy. So a problem-solving MRI was obtained. You can see here that there is an irregular spiculated mass in the same area that we saw on the mammogram. This is a subtle focus, but I'm saying irregular mass now for the new BIRADS terminology. And an MRI-guided biopsy was performed. You can see the obturator as denoted by the yellow arrow and well-positioned in the area of suspicious enhancement. And this indeed was an invasive carcinoma with ductal and lobular features. I think this is a really nice use of problem-solving MRI when you have discordant rad path on surgery. So this is another case of problem-solving MRI for a suspicious finding. This is a PET CT, 66-year-old woman. She's had a prior history of left breast cancer and as well as lymphoma. And you can see that there's a new breast mass on PET CT. And so she underwent diagnostic mammogram. The MLO views, you can see this is the current compared to 1 year ago and 5 years ago. The MLO views demonstrate skin thickening, which is unchanged, and the subareolar region is really difficult to evaluate due to the skin thickening. Similarly, on the CC views, you have stable skin thickening, current 1 year ago, 5 years ago, but you can see that it's very difficult to assess the subareolar region, but you know something is there because the PET CT shows it. So the ultrasound demonstrated a questionable subareolar mass. I find ultrasounding the subareolar region to be quite challenging. An FNA was performed because of the location near the nipple areolar complex, and this is a non-diagnostic FNA. Well, we know there's a mass there, so a problem-solving MRI was obtained. And you can see very well there's a homogeneously enhancing mass in the subareolar region corresponding to our PET CT. Because of the challenging mammo and ultrasound findings and the prior non-diagnostic FNA, we ended up doing an MRI-guided biopsy, and this is a recurrent invasive lobular carcinoma. The diagnostic performance of mammo and ultrasound in ILC detection is limited, and it ranges from 57 to 81%. And this is especially in patients with dense breast tissue or in the subareolar regions like in this case. So now I'm going to start talking about equivocal or uncertain imaging findings and the use of problem-solving MRI. So this is a very rare indication for breast MRI. It ranges from 0.1 to 0.7% of all breast MRIs, but the malignancy rate is quite high at 5 to 26% in the literature. So some of the scenarios that you may encounter is equivocal findings. A lesion is visible on some but not all views, and it's suspicious. Is it a change, a true change versus technical differences on mammo and ultrasound? And finally, as we've talked about a little bit already, is it a new finding at the lumpectomy and surgical site? So this is a case. This is a 49-year-old woman. She has a BRCA1 mutation in her screening mammogram. On the left MLO view, there's a possible new asymmetry in the upper breast. Compared to 1 year and 2 years prior, it's difficult to know, was this now included in view? Does she have some fatty involution of the breast? But she was called back from screening. And this is her screening mammogram, and you can see there was questionable persistence of the single view asymmetry on spot compression views as well as the true lateral view. And so it was not seen on the CC view, and the ultrasound was negative. So some of you may ask, what about single view tomosynthesis biopsy? We do not do it at our institution, and the reason is because if you place the clip in a single view, you do not know if the orthogonal view is if the clip is in correct position in the orthogonal view. And of course, the reason that we now don't do it is because we did have a QA case in which a biopsy had the clip not in the correct position on the CC view. The patient underwent surgery, and the cancer was not removed. She had a breast MRI. That's not this case, but that's the reason we don't do a single view asymmetry. But a problem-solving MRI was obtained in this particular case, and it was negative, so the case was placed back into screening because we felt with the finding in the high negative predictive value of problem-solving MRI, this patient was safe to go back to screening. Here's another case, 81-year-old woman here for a baseline screening examination. I think she went to a new primary care physician. And so you can see that there's a questionable area of distortion in the slightly lower central breast, that this is just a blow-up image of it, and she was called back for additional views. So on the day of diagnostic mammogram, you can see that there's no definitive persistent finding on mammography. Targeted ultrasound was negative. So this was dictated out as findings most likely relate to complex parenchymal pattern, BI-RADS3. We can argue if this is an appropriate use of BI-RADS3, however, the patient was placed in follow-up. At 6-month follow-up, interestingly, the same radiologist read this, and you can see that there is equivocal distortion here with possible correlate on the MLO view. At this point, the radiologist recommended problem-solving MRI, which I think is an appropriate indication. It does look suspicious on the CC spot. And this is the finding. So you can see there's a correlative heterogeneous mass in the left breast correlating with the distortion. So MRI-guided biopsy was performed, as this was very vague on mammography, not seen on ultrasound. MRI-guided biopsy demonstrated invasive carcinoma with ductal and lobular features, moderately differentiated. Again, these lobular carcinomas can be very challenging to see on mammography and ultrasound. Here's another case. This is a 66-year-old woman with new findings on screening mammography. And so you can see this is her current compared to her most recent prior, which was in 2017, so quite a while ago. And there's a new mass in the upper inner breast at posterior depth. And there's also a questionable focal asymmetry in the upper outer breast. This is new when compared to prior, and I always look at findings when I'm doing mammograms with new cancers, and I look at, has it developed at the same time frame as the cancer? If it is the same time frame as the cancer, then that increases my level of suspicion. So spot compression views were done, and you can see that this is the dominant mass, which ends up being an invasive ductal carcinoma. However, this additional tubular mass or focal asymmetry was not really well situated in the paddle. The radiologist recommended a breast MRI for both extensive disease and problem solving for the other area of concern, that focal asymmetry. I don't include the known cancer, but here you can see there's a very subtle linear homogeneous NME correlating with the mammographic focal asymmetry. So now we repeated the spot compression views with the appropriate positioning of the paddle, and you can see there's persistence of this tubular asymmetry. Here, we did a stereotactic biopsy, which demonstrated low nuclear grade micropapillary DCIS. So another nice use of problem-solving MRI, not only for extensive disease, but it also evaluated that focal asymmetry. So this is a 66-year-old woman. She has a history of left BCT and questionable distortion on her screening mammogram in the upper outer quadrant. This is one of those mammograms that I look at, and I really hope I don't have it at a Friday at 4:30 because it's just so dense, so complex, lots of dystrophic calcifications, scar marker, and you want to be you want to look at the scar and say, is this scar in relation to the scar marker? So there was worry about new scar developing versus architectural distortion, so she was called back. So the radiologist thought that there's possibly pliable tissue. Is it persistent distortion or not? They were unsure, so ordered a problem-solving MRI after a negative ultrasound. And this is where I think that problem-solving MRI is really helpful. So you can see here, as we talked about, the non-fat suppressed pre-contrast imaging demonstrating a hypointense scar here, and there's no enhancement in the area of post-surgical changes, so you can call this benign. Breast MRI has 90% sensitivity for differentiating scar from tumor recurrence, and if there's no enhancement, or if you have a thin area of enhancement, that can be considered benign. So now I'm going to move into my last category, which is negative imaging with clinical concern. And this is where I highly recommend, when you're doing a mammo and ultrasound on patients who come in with palpable concern, is that you do a physical examination on the patient as well. Because I think that if you have a negative mammo and ultrasound, that physical examination can be very helpful. So we'll start with pathologic nipple discharge, though, and this is when there's spontaneous, unilateral, single duct, bloody, clear, and watery. This is pathologic nipple discharge. We start with mammo and ultrasound. Negative MRI does not obviate the need for surgical management in suspicious discharge. We don't do ductography anymore. I think the last one I did was in 2016, and that's because MRI just has a better negative predictive value and positive predictive value. But not only that, MRI can also detect peripheral findings, as 20% of these lesions are greater than 3 centimeters away from the nipple. So this is a nice example. 37-year-old woman, new pathologic bloody nipple discharge, mammogram negative, ultrasound negative, no intraductal masses, no subareolar filling defects. So a problem-solving MRI was obtained. I did use the word lobular because I really like the word lobular. So this is a lobular subareolar mass. And sometimes you might see some ducts filled with fluid on your T2 weighted sequences. And what you're looking at for contrast-enhanced images are an intraductal lesion. And you can see here very nicely that there's this subareolar mass. Now that we see it under MRI, we can target our ultrasound better, and there's a beautiful correlate here at 8 o'clock, 1 to 2 centimeters from the nipple. This is an intraductal papilloma without atypia. And so, as we know, papillomas account for up to 70% of pathologic nipple discharge. If they're central, they're going to be retroareolar intraductal masses. Peripheral papillomas can occur. Discharge is less frequent. For nipple discharge, cancer can be seen in 20% of cases, with older patients more likely, and if they are cancer, it's often DCIS or intracystic papillary carcinomas. So what about skin changes? So patients may present to your breast clinic with skin changes, and the differential, of course, is mastitis, but it's also inflammatory breast cancer, Paget's disease, and skin involvement of cancer. You always, again, start with mammogram and ultrasound. If negative imaging, we often refer to our breast center or surgeon for a skin punch biopsy. But MRI is still helpful. If negative, skin punch biopsy, consider MRI or surgical biopsy, and if positive, consider MRI for extensive disease. So here you can see the patient presented. Here's the palpable marker. In the lower inner breast, there is skin thickening in this area. However, there's no underlying lesion. Ultrasound was reportedly negative. Of course, ultrasound is a real-time examination, and so a breast MRI was ordered. And you can see here that there is a focal area of heterogeneous NME, mildly enhancing, that's asymmetric from the contralateral side and corresponds with the area seen on mammography. Here's the associated skin thickening and tenting. So we went back to ultrasound. You can see the focal thickening, but there's also this subtle non-mass ultrasound finding, and that was targeted for biopsy. And this demonstrated, again, mixed lobular. It's that lobular component that causes us trouble, mixed lobular and ductal, hormonally positive, HER2 negative cancer. So although mammo and ultrasound has a high negative predictive value if a patient comes in with a clinical concern, it's really important to consider to do a physical examination and consider a breast MRI if it's not amenable to palpation-guided biopsy or if you don't have anyone who can do a palpation-guided biopsy. Some considerations include, of course, young age, dense breast tissue, and high-risk factors such as family history and genetic mutations. So some of these cases are really quite remarkable. This is a 40-year-old woman. She has a palpable finding in the right breast. Extremely dense breast tissue, can't see anything. There's no calcifications here. And an ultrasound was done, and all you see is this dense breast tissue. This is in the area of palpable concern at 12 o'clock periareolar. The radiologist on the day did a nice physical examination and recognized that the palpability was suspicious and ordered a problem-solving MRI. And you can see here that there is regional clumped NME in the upper inner breast on the right, corresponding to that palpable area of concern. And you can see here the corresponding area on sagittal view, and this is an invasive carcinoma with mixed features. So again, do a physical examination, see how clinically suspicious the area is. Similarly, this is a 54-year-old woman with a palpable finding in the right breast. The mammogram was considered negative, and at 11 o'clock in the area of palpable concern, a vague hypoechoic area was recommended for biopsy. But on the day of biopsy, the radiologist, it was a different radiologist, and they couldn't reproduce it, so they placed her into 6-month follow-up. At 6-month follow-up, you can see there's still a persistent, vague, non-mass ultrasound finding, and at that point, a breast MRI was recommended. Problem-solving MRI demonstrates an area of clumped NME in the outer upper breast, and you can see that it is suspicious, corresponds to the area of palpable concern. MRI-guided biopsy demonstrated ductal carcinoma in situ. So as I mentioned, there's always appropriate reasons and inappropriate reasons to use breast MRI. And I'm going to talk about a few inappropriate reasons. I mentioned this before, and I'll mention again, it should not replace mammogram and ultrasound. It should not be used when mammogram and ultrasound or clinical examination can guide biopsy. Evaluation of mammographic calcifications, particularly for short interval follow-up, and breast pain. Breast pain, nearly 100% negative predictive value for mammogram and ultrasound. There is no data to show that MRI is indicated, no risk-benefit, not cost-effective. So a few weekends ago when I was on call, I get a 43-year-old woman, BRCA positive, and the indication, because she just recently had a breast MRI, was left breast pain. I go to her patient jacket, no mammo, no ultrasound, just MRs. And you can see at least they put a nice palpable marker there for me. However, the MRI is negative. So again, problem-solving MRI is not indicated. First-line imaging is mammo and ultrasound. If mammo and ultrasound is negative and the clinician feels like it's very suspicious, MRI can be performed. If there's a palpable finding, you can do palpation-guided biopsy or clinical management. This is another example where breast MRI is not indicated. 36-year-old woman with calcifications on her baseline MR. They don't project very well, but there is 2.5 centimeters of punctate and amorphous calcifications in the central outer breast. The patient has a vasovagal, and the stereotactic biopsy is aborted. And so a breast MRI was obtained, and of course, there was no enhancement in the right breast, but that's because these are calcifications. And so we brought the patient back to the clinic, gave her some she was given some anti-anxiolytics prior. Repeat stereo was performed successfully, and this is ductal carcinoma in situ. So problem-solving MRI is not indicated for the evaluation of calcifications or short interval follow-up for calcifications. We have to remember that low-grade DCIS is less likely to enhance on MRI. Do image-guided localization and excision for suspicious calcifications if stereotactic-guided biopsy is unable to be performed. So in conclusion, we talked about appropriate problem-solving MRI, lesions visible on some but not all views, is it technique or real change, evaluating the lumpectomy site, discordant biopsy, and clinical situations such as nipple discharge or persistent clinical findings despite a negative mammo or ultrasound. Thank you very much.